This video is about 42 years female post-abdominal hysterectomy case who was referred to us with complaints of continuous dribbling of urine, and on examination she had vesicovaginal fistula. So we repaired vesicovaginal fistula by laparoscopic route with extravesical repair was done. So extravesical repair is minimal invasive alternative to classic O-corner transvesical technique. So this surgery repairs the fistula by dissecting the bladder away from the vagina externally and closing the defects separately and placing the tissue interposition flap. So in this case, now you are seeing there are a lot of adhesions to the vault. But the sigmoid ovaries are all everything is adherent. So the adhesionolysis was done with the help of harmonic scalpel. The meticulous dissection was done, and all the adhesions are released. And then we start to mobilize the bladder. So post abdominal hysterectomy, the most common site will be at the site of supratrigonal area. That is most because of taking the stitch through the bladder, and this usually will the fistula comes to know only after 8 to 9 days, wherein the patient starts complaining of continuous dribbling of urine. So this patient was referred to us after 4 weeks of surgery, and now you are seeing once the adhesionolysis was done, where the bowel was mobilized above. Now you can see we have manipulated the vault with the help of sponge holding forceps from the vaginal end. So this helps us to dissect the bladder very easily, and even we mobilized the rectum. Suppose the vault also gets opened, we must not fear it, because again we have to we can suture the vault once the fistula is repaired. Here the main methods used is, before proceeding for laparoscopic surgery, we did the cystoscopy, we identified the fistula, then we stunted both the ureters, and then we started surgery from above. So identification of the bladder and then the mobilization of the bladder is the most important. We have to dissect the bladder away from the vaginal wall, and this itself now you are seeing is the fistula. Actually, now we have dissected it, as you are seeing the opening of the bladder there, dissected, and we mobilized the bladder above. So we have to develop vesicovaginal space, and slowly, once the fistula is identified, we have to circumferentially dissect it and create a 1 to 2 centimeter of healthy tissue around the fistula before suturing the fistula. So this creating a healthy tissue prevents the recurrence of the fistula later on. So what's the difference between O-corners and extravesical repair is, O-corners we go through the bladder, identify the fistula, then separate the fistula tract from the vaginal wall, then we suture separately. But in extravesical repair, we will not go through the bladder, we will mobilize the bladder from below, from the vagina, and then we identify the fistula and then we suture it. So now next question, usually most of them will have, when we have to repair the fistula. So again it depends on the condition. If you are identified at 8th or 9th day of the post surgery, you can immediately repair if the patient condition is healthy, and if the patient has comorbid factors like diabetes and all. So in such cases, usually we can wait for 3 months. Once the fistula becomes healthy, then we can go for a repair. So now you have seen we have freshened the edges of the fistula, and then with the help of 20 Vicryl, or even you can use the barb suture also, we can close it by continuously or interrupted sutures. First the one layer mucosal approximation, and next we have to mucosal layer reinforcement is done. As I told this, then we will interpose with the omental flap, which will reduce the recurrence of the fistula. Now, does it require a complete leak proof repair? Yes, we can check whether it's or the repaired fistula, is there any leak, by instilling a 200 to 300 ml of diluted methylene blue, and then we can confirm the leakage. Then next will be whether we have to put the pelvic drain or not post surgery. Again, it depends on the surgeon. If in hands of expert surgeon, usually there is no need to put a pelvic drain. Here we usually don't put a pelvic drain. We have done many cases of fistula. As our center is a referral center for complicated laparoscopic cases, we have done so many fistula repairs, and usually we not keep a pelvic drain, and Foley's catheter is kept for almost 14 days to 21 days. And some surgeons they prefer to keep a suprapubic catheter. So even we again depends on the case. We usually don't keep a suprapubic catheter, but even keeping a suprapubic catheter helps a lot. So compared to O'Connor, again here there is a no bladder bivalving. There will be a very less bleeding, as you are seeing, and less of bladder spasm, and there is a faster recovery and less post-operative irritative symptoms of the bladder, and success rate is 90 to 98% in this case. Okay. So ideal indications for extravesical repair are: one is the post-hysterectomy fistula, small to moderate fistula like 0.5 to 2 centimeter of fistula, and even recurrent fistula when previously it was done by vaginal route, we can opt for laparoscopic extravesical repair in such cases. So what are the contraindications for extravesical repair? Again, if a patient has previous history of radiation, so radiation fistula or large fistula with a lot of tissue loss, or there is any involvement of ureteric orifice, and in such cases we often prefer O'Connor transvesical repair. The important surgical tips is one is we have to ensure tension free closure and avoid overlapping of suture lines, and always you have to use interposition tissue and maintain adequate bladder drainage. So now you are seeing there we have closed the vault, and once we have checked the bladder integrity, we have interposing the momentum in between the bladder and the vagina. So keep following the videos. You will be finding very much interesting videos. I will be posting in the YouTubes, some difficult cases and some simple cases also. So please keep watching, and if you have any doubts and comments, I'll feel free, and even if there are any mistakes in this surgery, you can please comment, so that it will help us even for me to improve. Thank you, And please subscribe and even forward to your postgraduates, so it will be for easy learning. And most important, one more thing is, everyone learn to do cystoscopy and ureteric catheterization. Thank you. Thanks.